Society for the Study of Pain. And also, my co-chair is Professor Mian Tao, consultant orthopedic surgeon and the patron of Myanmar Orthopedic Society. So let's start on this very interesting symposium of abject on neuropathic pain. The first speaker, today three eminent speakers will be discussed in these interesting topics. Our first speaker, Professor Mian Wu, will be discussing on clinical perspectives of neuropathic pain. Professor Miu is a professor of the neurology in clinic from the Mandalay University of Mandalay. University of Mandalay, Departments of Neurology, and from the Mandalay General Hospitals. So please start, Professor Miu, to talk about the clinical perspective of neuropathic pain.
အားလုံးပဲမင်္ဂလာပါဒီနေ့ကျွန်တော်ပြောမယ့်ခေါင်းစဉ်ကတော့ clinical perspectives on neuropathic pain ဖြစ်ပါတယ်ကျွန်တော်ကတော့ Manly Neurology Department ကဒေါက်တာဦးမြင့်ဖြစ်ပါတယ်ဒီ slide ကတော့ကျွန်တော်ပြောမယ့်เนาะ presentation ရဲ့ topic outline တွေဖြစ်ပါတယ် case issue နဲ့စပါမယ်ဒီ case မှာပြန်ကြည့်မယ်ဆိုရင်တော့ 63-year-old gentleman with body control type 2 diabetes for 25 years with recent A1C of 8.8%. He presented with 6 months history of sleep disturbance from symmetrical burning pain in his feet. He first noticed the pain at night and then increasingly difficult to walk unless he was wearing certain shoes and his feet hard with any movement. He also feels walking on cotton and he cannot navigate without washing his feet, and at night he must hold onto furniture and walls. His overweight, resting parts are wanted, and orthostatic hypotension. There are absent reflexes with distal muscle wasting in both hands with bilateral foot drop. He has loss of touch, joint position sense, and awareness of pain breaking, glove and stocking pattern. Homeostasis is strongly positive, and there is background and proliferated diabetic retinopathy. These are the common phenomena of painful diabetic neuropathy in a patient with poorly controlled diabetes mellitus. From neurological point of view, he has gland-dependent neuropathy involving not only myelinated fibers, but also fast contacting myelinated fibers, serving soft touch and joint position sense. Next topic introduction. Definition of neuropathic pain. It is defined as a pain caused by primary lesion or dysfunction of the nervous system. It results from damage anywhere along the neuraxis, including peripheral nervous system, spinal or supraspinal nervous system. It is different from nociceptive pain. Neuropathic pain are lesion in the somatosensory system ကြောင့်မလို့ဖြစ်လာတဲ့เนาะ pain ဖြစ်တယ်။ဒါပေမဲ့လည်း nociceptive pain ကတော့ nociceptor စီ activation ဖြစ်ပြီးတော့ non-neural tissue စီ damage ကြောင့်မလို့ရလာတဲ့ pain ဖြစ်ပါတယ်။အဲ့ဒီမှာတော့ somatosensory nervous system ကတော့ functionally intact ဖြစ်တာကိုတွေ့ရပါတယ်။ Impact of neuropathic pain မှာ evidence indicates that neuropathic pain impairs a patient's mood, quality of life, activities of daily living, and performance at work. There is 7 to 8% prevalence of neuropathic pain in general population. Next topic are pathophysiology and molecular mechanisms of neuropathic pain ဖြစ်ပါတယ်။ pathophysiology background ကိုပြန်ကြည့်မယ်ဆိုရင်တော့လေ peripheral mechanism ရှိတယ်လို့ central mechanism နဲ့ pathogenesis မှာပါတာကိုတွေ့ရတယ်။ injury ရသွားတဲ့အခါ injury axons နဲ့ nerve territory တစ်ခုထဲမှာရှိတဲ့ intact axons တွေကသွားပြီးတော့ abnormal signal ကိုထုတ်ပေးလိုက်ပါတယ်။ pathogenesis မှာအဓိကတော့ peripheral, central mechanism နဲ့ sympathetic mechanism တွေလည်းရှိပါတယ်။ ဒီပေါ်ကတော့ primary efferent pathways that convey the pain signals ဖြစ်ပါတယ်။ peripheral မှာ nociceptor တွေ nerve endings တွေမှာ nociceptor တွေရှိတယ်။သူမှတစ်ဆင့် efferent fibers တွေက dorsal horns ကိုရောက်လာတယ်။ dorsal horns မှာရှိတဲ့ second order neurons တွေနဲ့တွားပြီးတော့interact လုပ်တယ်။ second order neuron cell axons တွေက other side ကို cross over လုပ်ပြီးတော့ thalamus မှာတွားပြီးတော့ delay လုပ်တယ်။အဲ့ဒီမှာ third order neuron တွေနဲ့တွားပြီးတော့တွေ့တယ်။ third order neuron cell axons က cortex မှာ cerebral cortex မှာအဆုံးသတ်တာကိုတွေ့ရပါတယ်။ peripheral nerve ending စီမှာ injury changes တွေဖြစ်တဲ့၎င်း central မှာ changes တွေဖြစ်တဲ့၎င်း poison မှာ dorsal root ganglion နဲ့ spinal cord မှာ changes တွေကြောင့်မို့လို့ neuropathic syndrome တွေကိုတွေ့ရပါတယ် primary afferents တွေကိုပြန်ကြည့်မယ်ဆိုတော့လေသူတို့ရဲ့အခန်းအမိကြောင့် myelination နဲ့ connection velocity မှာမူတည်ပြီးတော့ nerve fibers တွေကို classification လုပ်ထားတယ်အဲ့မှာ nerve fiber type တွေများ A B C ရှိတယ် A နဲ့ B ကတော့ myelinated fibers တွေဖြစ်ပြီးတော့ C ကတော့ unmyelinated venous fibers တွေဖြစ်တယ် A ကတော့ largest fibers တွေဖြစ်ပါတယ် A မှာမှ subtype တွေနဲ့ alpha beta delta ရှိတယ်အဲ့ nerve fiber different types တွေထဲမှာမှ A beta A delta နဲ့ group C fiber တွေကတော့ကျွန်တော်တို့ရဲ့ primary afferents မှာအဓိကပါဝင်တဲ့ nerve fiber တွေဖြစ်ပါတယ် A beta ကတော့ touch sensation အတွက်ဖြစ်ပြီးတော့ delta ကတော့ pain temperature အတွက်ဖြစ်တယ် C ကတော့ visceral somatic afferent နဲ့ burning pain တွေဖြစ်ပါတယ် nerve damage ဖြစ်တဲ့အခါမှာ proximal nerve stem မှာ degenerative nerve spots တွေပေါ်လာတယ်အဲ့ဒါကို neuroma လို့ခေါ်တယ်အဲ့လိုပဲ similar pattern စာလဲဘေးပတ်ဝန်းကျင်မှာရှိတဲ့ intact ဖြစ်တဲ့ injured neuron တွေမှာလည်းတွေ့ရတယ်အဲ့ဒါကြောင့်မို့လို့သူတို့ရဲ့ receptive feature နဲ့ expansion ဖြစ်တာကိုတွေ့ရပါတယ်အဲ့ဒီမှာအရေးကြီးတဲ့ mechanism တစ်ခုကတော့ sensitization ဖြစ်တယ် sensitization ဆိုတာကတော့ intense repeated prolonged stimulus တွေပေးလိုက်တဲ့အခါမှာ damage tissue တွေမှာသွားပြီးတော့ stimulus တွေရလာတဲ့အခါမှာသူတို့ရဲ့ primary afferent nociceptor တွေရဲ့ threshold ကကျနေတာကိုတွေ့ရတယ်အဲ့ဒါကို sensitization လို့ခေါ်ပါတယ် sensitization ကတော့ peripheral level မှာဖြစ်တယ်လို့ပဲ central level မှာတော့ dorsal horn of the spinal cord မှာတွေ့ရပါတယ် peripheral sensitization အနေနဲ့ကတော့လေ pathophysiological mechanism မှာပြန်ကြည့်မယ်ဆိုတော့လေ channel sodium ion channel expression changes ကိုတွေ့ရပါတယ်အဲ့မှာ sodium channel ပါမယ် calcium channel ပါမယ် calcium channel expression ပြောင်းလဲမှုကြောင့်မို့လို့ substance P နဲ့ glutamate တွေ release လုပ်ပေးလိုက်ပါတယ် ion channel expression alteration ဖြစ်တဲ့ကြောင့်မို့လို့ neuron တွေကပို့ပြီးတော့ hyper excitable ဖြစ်လာတယ် atopic activity တွေသူကပေါ်လာကြတယ်အဲ့ဒါကြောင့်မို့လို့ spontaneous and proximal pain ကိုဖြစ်ပေါ်စေပါတယ် at the same time မှာပဲ normal physiological condition မှာ marginally express ဖြစ်တဲ့ membrane မှာပေါ်နေတဲ့ protein တွေရှိတယ် various protein တွေရှိတယ်အဲ့ protein တွေကလည်း nerve injury ဖြစ်တဲ့အခါမှာ upregulation ဖြစ်တာကိုတွေ့ရပါတယ် next mechanism တစ်ခုကတော့peripheral sensitization မှာအဓိကပါတဲ့ mechanism တစ်ခုကတော့ cytokine formation ဖြစ်တယ် peripheral nerve injury မှာဖြစ်ပေါ်လာတဲ့ဝင်လာတဲ့ infiltrative macrophages တွေနောက် T cells တွေနဲ့ mast cells တွေမှာတစ်ဆင့် cytokine formation တွေဖြစ်ပေါ်စေတယ်အဲ့ဒီ cytokine မှာတစ်ဆင့်ဒီ peripheral mechanism neuropathic pain ကိုအဓိကပါဝင်တာကိုလည်းတွေ့ရပါတယ် next mechanism ကတော့ central mechanism ဖြစ်ပါတယ် normal nerve terminal တွေမှာ signal တွေကို axon မှာတစ်ဆင့် dorsal root ganglion ရအောင်ပို့ပေးတယ် dorsal root ganglion မှာရှိတဲ့ cell body က gene transcription နဲ့ protein synthesis ကို modify လုပ်ပေးလိုက်တယ် nerve damage ဖြစ်တဲ့အခါမှာအဲ့ဒီ mechanism ကပျက်စီးသွားတာကိုတွေ့ရပါတယ် central sensitization မှာအဓိကပါဝင်တဲ့factors တွေကတော့အဲ့ dorsal horn မှာရှိတဲ့ nerve cells တွေကလည်းပို့ပြီးတော့ hyper excitable ဖြစ်လာကြတယ် at the same time မှာပဲသူတို့ရဲ့ affected area site expansion ဖြစ်လာကြတယ်အဲ့အတွက်ကြောင့်မို့လို့သူတို့က painful နဲ့ non painful stimulus တွေကို response လည်းပို့ပြီးတော့များတာကိုတွေ့ရပါတယ် dorsal horn မှာရှိတဲ့ neuron တွေမှာ pre-synaptic terminal တွေနဲ့ post-synaptic terminal တွေတစ်ခုစလုံးမှာ changes တွေကိုတွေ့ရပါတယ် nerve injury ဖြစ်တဲ့အခါမှာ pre-synaptic nerve terminal မှာ various neurotransmitters တွေပေါ်လာတယ်အဲ့ဒါတွေကတော့glutamate တွေပါတယ် substance P နဲ့ brain trust neurotrophic factors တွေနဲ့ other peptides တွေပါပါတယ်အဲ့ထဲမှာမှ glutamate ကမျိုး major transmitter ဖြစ်တယ်သူကတော့ dorsal horns မှာရှိတဲ့ neurons တွေ rapidly excitation ဖြစ်ပေါ်စေတာကိုတွေ့ရပါတယ် other peptides တွေဖြစ်တဲ့ substance P နဲ့ CGRP ကတော့ slower and longer lasting excitation of the dorsal horn neurons တွေကိုဖြစ်ပေါ်စေပါတယ် post synaptic terminal တွေမှာလည်း changes တွေအနေနဲ့တော့ neurotransmitter တွေထွက်လာတဲ့အခါမှာသူတို့မှာ post synaptic membrane မှာရှိတဲ့ receptors တွေ activation ဖြစ်လာတယ်အဲ့မှာအရေးကြီး receptors တွေကတော့ glutamate anti-drug NMD receptor ရှိတယ်လို့ပဲ calcium anti-drug alpha receptor တွေဖြစ်တယ်အဲ့ဒါကြောင့် intracellular calcium နဲ့ intracellular cyclic AMP formation တွေများလာတယ် အဲအကြောင်းမလို့ gene transcription ကိုပို့ပြီးတော့ modulation လုပ်ပေးလိုက်ပါတယ် at the same time မှာပဲ potassium channel transcript expression ကလည်း post synaptic membrane တွေမှာလျော့လာတာကိုတွေ့ရပါတယ် another mechanism မှာတော့ pro-inflammatory cytokine formation ဖြစ်တဲ့ dorsal horn မှာသူတို့ကဆိုလို့ရှိရင်တော့လေ gland cell activation ဖြစ်ပြီးမှတစ်ဆင့်ပေါ်လာကြတယ်အဲ့ဒီ cytokine တွေ prostaglandin တွေကလည်း pain transmission အတွက်အများကြီးအထောက်အကူပြုပါတယ် another mechanism တစ်ခုကတော့ disinhibition mechanism ဖြစ်ပါတယ်သူတို့ကဆိုရင်တော့လေ normally မှာဆိုတော့လေ primary efferent terminal တွေနဲ့ post synaptic neuron တွေမှာ inhibitory receptor တွေဖြစ်တယ်နောက် immunity ဖြစ်တဲ့အခါမှာ the receptor တွေ expression ကလျော့ကျနေတာကိုတွေ့ရပါတယ် another mechanism ကတော့ descending modulating mechanism တွေဖြစ်ပါတယ် cortex မှာ cortex ရဲ့ thalamus ရဲ့ periaqueductal gray matter of the midbrain အဲ့ဒီမှာတစ်ဆင့်ဒီเนาะဒီ sickness ရဆိုလို့ရှိရင်တော့လေ rosary ventricular မှာတွားပြီးတော့ converse လုပ်ကြတယ်အဲ့ဒီ medulla မှာအဲ့ဒီ medulla မှာရှိတဲ့ neuron မှာတစ်ဆင့် inhibitory excitatory pathway မှာတစ်ဆင့် dorsal horn မှာရှိတဲ့ pain transmission ကို modulate လုပ်ပေးတာကိုတွေ့ရပါတယ် another mechanism ကတော့ sympathetically maintain pain ဖြစ်ပါတယ် sympathetic mechanism ကလည်း pathogenesis of neuropathic pain မှာအရေးကြီးပါတယ်ဘာလို့လဲဆိုလို့ရှိရင်တော့ sympathetically လုပ်ပြီးလို့ရှိရင်တော့လေ analgesia effect ကိုတွေ့ရတယ်နောက်ပြီးတော့เนาะဒီ sympathetic nervous system activation ဖြစ်ခြင်းအပြင် pain exacerbation ကိုတွေ့ရပါတယ်နောက် next mechanism တစ်ခုကတော့ injural neuron တွေမှာလေ sympathetic neuron တွေဟာနောက်တော့ zero ganglion မှာ stroking ဖြစ်တာကိုတွေ့ရပါတယ်နောက် clinical presentations and patient evaluation မှာဒါကတော့เนาะ neuropathic pain မှာဆိုတော့လေ peripheral nervous system မှာ central nervous system တစ်ခုစလုံးမှာ pathology တစ်ခုရှိရင်တော့လေတွေ့ရတယ် for example nerve အနေနဲ့ကြည့်မယ်ဆိုတော့လေ carpal tunnel syndrome painful diabetic neuropathy trigeminal neuralgia နဲ့ lemniscate plexopathy က good example common example တွေဖြစ်ပါတယ် dorsal ganglion မှာ lesion ရှိရင် for example postherpetic neuralgia မှာလည်း neuropathic pain ကိုတွေ့ရပါတယ် central nervous system အနေနဲ့ spinal injury pain တွေရှိတယ်လို့ပဲ post stroke pain နဲ့ multiple sclerosis pain တွေလည်းတွေ့ရပါတယ် positive symptoms of neuropathic pain neuropathic pain မှာဆိုတော့ positive နဲ့ negative symptoms တွေနဲ့ present လုပ်ပါတယ် positive symptoms တွေထဲမှာ spontaneously ဖြစ်ပေါ်လာတဲ့ pain ရှိတယ်လို့ပဲ stimulus ပေးလို့ရှိရင်ပေါ်လာ evoke pain တွေရှိပါတယ် spontaneous pain မှာတော့ power အစီးစရာရှိတယ် calling sensation တွေဖြစ်တယ် stabbing pain တွေဖြစ်တယ် electric shock like sensation တွေရှိတယ် submersion pain ကတော့ burning pain တွေရှိပါတယ် evoke pain တွေများ allodynia ဖြစ်တယ် allodynia ကတော့เนาะဒီ clothing တို့ light breeze เนาะ non painful stimulus မှာ pain ရတာဖြစ်တယ် hypergesia ကတော့เนาะ painful stimulus ကိုပို့ပြီးတော့ exaggerated pain ရပြီးတော့ hyperpathy ကတော့เนาะ mild or nociceptive or inocular stimulus မှာ exaggerated pain ရတာဖြစ်ပါတယ် negative symptoms တွေနဲ့ကတော့ hypoaesthesia ကတော့ non painful stimulus ကို sensation နည်းနေရဖြစ်တယ် hypoagesia ကတော့ painful stimulus ကို sensation နည်းနေရဖြစ်ပြီးတော့ bad hypoagesia ကတော့ vibration sensation ကိုနည်းနေတာဖြစ်ပါတယ်ဒီလို neuropathic pain ဖြစ်တဲ့ patient တွေကိုဘယ်လို assessment လုပ်မှာလဲများသောအားဖြင့်တော့ treatable condition ဆို exclude လုပ်ဖို့အရေးကြီးပါတယ် for example spinal cord compression neoplasm တွေဖြစ်ပါတယ်နောက်သူနဲ့တွဲပြီးရှိတဲ့ clinical features တွေကိုလည်းရှာဖို့အရေးကြီးတယ် for example insomnia mood changes တွေနဲ့ autonomic neuropathy တွေဖြစ်ပါတယ်သူတို့ရှာ identify လုပ်ခြင်းအပြင် individualized treatment တွေကိုများစွာအထောက်အကူပြုပါလိမ့်မယ် neuropathic pain ရဲ့ diagnosis ကတော့ primarily ကတော့ history နဲ့ physical findings တွေမှာအဓိကမူတည်တဲ့ sun special test လည်းပါဝင်ပါတယ် history အနေနဲ့ကြည့်မယ်ဆိုတော့ pain intensity ကိုအဓိကမေးဖို့လိုအပ်တယ်အဲ့ဒီမှာဆိုတော့0 to 10 rating scale ရှိတယ်သူတို့ကဆိုလို့ရှိရင်တော့လည်း pain treatment response တက်လည်းအများစွာအထောက်အကူပြုပါလိမ့်မယ်နောက်တစ်ခါ sensory description ဘယ်လိုမျိုး patient က describe လုပ်ပေးရလဲ for example pain quality တွေနဲ့ hot burning pain sharp pain stabbing pain တွေရှိတယ် non painful sensation တွေနဲ့ tingling prickling itching နဲ့ numbness တွေရှိတာကိုတွေ့ရပါတယ် temporary variation နဲ့ neoplastic process တွေကတော့ pain ကတော့ neoplastic process တွေမှာတော့ progressively ပိုဆိုးလာအောင်တွေ့ရတယ် pressure နဲ့ impact အနေနဲ့ကတော့ sleep work self care activities ဆို daily living မှာတော့ functional impact เนาะဘယ်လိုရှိရလဲသိဖို့လိုအပ်ပါတယ် attempted treatments တွေနဲ့ frequency of dose ဆိုသိဖို့လိုတယ်လို့ပဲ go of substance abuse မှာတော့ addiction history ကိုလည်းသိဖို့လိုအပ်ပါတယ် physical examination အနေနဲ့တော့ motor မှာတော့ motor weakness ဆိုရှာမယ် reflexive changes ဆိုလည်းသိဖို့လိုအပ်တယ် sensory examination အနေနဲ့တော့ light touch pain break vibration sense and jet position sensation ကိုလည်းစမ်းဖို့လိုအပ်တယ် skin examination အနေနဲ့ကတော့လည်းเนาะ odor temperature color sweating နဲ့ hair growth เนาะဒီဟာတွေကတော့ symptomatic changes တွေနဲ့ skin examination မှာတွေ့နိုင်ပါတယ် different neuropathic pain syndrome ကိုပြန်ကြည့်မယ်ဆိုတော့လေ painful diabetic neuropathy ကတော့ symmetrical sensory loss and burning pain ကိုလိုအပ်နေမှာတွေ့ရပါတယ် hemocerebral reticulopathy အနေနဲ့ lancinating pain radiating to the anterior thigh or lower legs associated with the motor weakness or sensory loss တွေနဲ့တွေ့ရပါတယ် နောက် post herpetic neuralgia ကတော့ affected ထားမဲ့တုံးမှာတော့ pain နဲ့ sensory loss အဲ့လိုတိုင်းများတွေ့ရပါတယ် HM-related neuropathy အနေနဲ့ကတော့ symmetrical painful paresthesia especially in the feet เนาะတွေ့ရပါတယ် complex regional pain နေ syndrome အနေနဲ့ type 1နဲ့ type 2ရှိတယ်သူတို့မှာဆိုတော့လေ regional pain အပြင် symptomatic changes တွေဖြစ်တဲ့ edema cutaneous blood flow abnormalities နဲ့ sweating abnormalities တွေလည်းတွေ့ရပါတယ် post surgical neuropathic pain အနေနဲ့တော့ peri-incisional sensory loss and pain and allodynia for more than 3 months after surgery ဖြစ်ပါတယ် phantom pain တွေလည်းတွေ့ရပါတယ် ဘယ်လိုမျိုး assessment လုပ်မှာလဲ assessment ဆို neuropathic pain မှာ next topic ကတော့အဲ့ဒီမှာတော့ diagnosis and assessment အနေနဲ့ကတော့เนาะ pain quality assessment scale တွေရှိပါတယ်အဲ့ဒီမှာ lead assessment ဆို neuropathic symptom and sign scale တွေရှိတယ်နောက် neuropathic pain question တွေဖြစ်တယ်နောက် dollar neuropathic question တွေရှိပါတယ်သူတို့ကတော့ treatment response အတွက်အရေးကြီးတယ်လို့ပဲ neuropathic pain နဲ့ non neuropathic pain ကိုခွဲခြားဖို့အတွက်လည်းအရေးကြီးပါတယ်အဲ့မှာ and least assessments on neuropathic symptom and sign scale အနေနဲ့ကတော့ pain question တွေစီပါတယ် sensory test တွေပါတယ်အမှတ်24မှတ်ပေးပြီးတော့ less than 12ကတော့ unlikely neuropathic pain ဖြစ်တဲ့ more than 12ကတော့ likely neuropathic pain ဖြစ်ပါတယ် special test တွေက CT MRI scan ကတော့ specific diagnosis အတွက်အများအထောက်အကူပြုပါတယ် for example herniated disc တွေ nerve infiltration မှာ tumor ကိုသိနိုင်တယ် EMG NCS ကလည်း neuropathic pain မှာ role ရှိပါတယ် for example NCS ကတော့ large spinal function အတွက်ကို evaluation လုပ်ပေးနိုင်တယ်ဒါပေမဲ့လည်း small spinal neuropathy အတွက်ကတော့သူကအဲ့မှာ normal ဖြစ်တာကိုတွေ့ရလိမ့်မယ်အဲ့ဒါကြောင့် normal မှာဆိုရင် small spinal neuropathy ကိုလည်း normal NCS မှာလည်း small spinal neuropathy ကို exclude မလုပ်နိုင်ပါဘူးနောက် clinical biochemistry အနေနဲ့ကတော့ neuropathic pain ရဲ့ cause ကိုသိနိုင်တယ် for example glucose testing thyroid function testing နဲ့ဒီအတွက် testing တွေအတွက်အရေးကြီးပါတယ် next topic ကတော့ neuropathic pain နဲ့ COVID-19 ဖြစ်ပါတယ် COVID-19 pandemic period မှာ post COVID symptom အနေနဲ့ neuropathic pain ကတော့ common ဖြစ်ပါတယ်အဲ့ဒီမှာအဓိက manifestation တွေနဲ့ neuralgia hypergeusia နဲ့ allodynia တွေတွေ့ရပါတယ် one series မှာဆိုတော့ hospitalized patients 2.3% မှာ neuropathic pain ကိုတွေ့ရပါတယ်အဲ့ဒီမှာအဓိက mechanism တစ်ခုကတော့ immune mediated small fiber neuropathy ဖြစ်ပါတယ်အဲ့ဒီမှာအဓိကပါတဲ့ pathogenesis cytokine storm ရဖြစ်လာပြီးတော့ immunotherapy with IVIG ပေးခြင်းအပြင် pain ကိုသက်သာစေတာကိုတွေ့ရပါတယ်နောက်ဆုံး big conclusion အနေနဲ့ကတော့ neuropathic pain ကတော့ chronic debilitating condition တစ်ခုဖြစ်တယ် diagnosis ကတော့ history နဲ့ physical finding မှာအဓိကအရေးကြီးပါတယ်အဲ့မှာ interrelated mechanism တွေဖြစ်တဲ့ peripheral spinal နဲ့ brain events တွေကလည်း neuropathic pain မှာအဓိကပါဝင်ပါတယ်အရင်ကတော့ disease based treatment မှာတစ်ဆင့်အခုနောက်ပိုင်းမှာဆိုတော့ mechanism based therapy ဖြစ်ဖို့ပြောင်းလဲလာကြပြီအဲ့ဒါကြောင့်မလို့เนาะ underlying mechanism ကိုတော့သိဖို့အတွက်အရေးကြီးလာပါပြီဒါပေမဲ့လည်း bad mechanism က operation ဖြစ်တာလေ individual symptomatology ကဘယ်ဟာ responsible ဖြစ်ပေါ်စေတာလဲဆိုတာကိုတော့လေသိဖို့တက်က challenging plan တစ်ခုဖြစ်ပါတယ်ဒါပဲပြော underlying mechanism ကိုသိခြင်းအပြင်ပုံမပြီးသိခြင်းအပြင် novel target for drug therapy အတွက်များစွာထောက်ပြုမယ်လို့ပဲညွှန်လင်းမိပါတယ်အားလုံးပဲကျေးဇူးအများကြီးတင်ပါတယ်
Thank you, Professor Mew. Professor Mew က the clinical perspective of neuropathic pain ကို the physiology of pathology or clinical manifestations တွေကိုပြည့်စုံစုံလေးပြောသွားတာပါအရန်ကောင်းပါတယ်ကျေးဇူးတင်ပါတယ် The second speaker is a Professor Phipule. Phipule is a professor and head and senior consultant neurologist, departments of neurology, Yangon General Hospital, University of Yangon. She is currently vice president of Myanmar Neurological Society and the counselor of Myanmar Pain Society. So I would like to invite Dr. Phipule to talk about topics with the evidence-based pharmacological treatments of neuropathic pain.
Good afternoon to you all. Thank you, Mama Professor Wimite, for your kind introduction. Today's topic I would like to discuss is evidence-based pharmacological treatment of the neuropathic pain. These are the contents of my topic. And what is neuropathic pain? International Association for Study of Pain 2018 defined the neuropathic pain as pain caused by a lesion or disease of the somatosensory nervous system. And this figure showed updated grading system for the neuropathic pain. When patients complain of the pain, we have to take a history of relevant neurological lesion or the disease and the pain distribution neuroanatomically plausible. If there is no such history, it is unlikely to be neuropathic pain. If yes, it is possible neuropathic pain. On examination, if pain is associated with the sensory signs in the same neuroanatomically plausible distribution, it is probable neuropathic pain. And we have to discuss diagnosis and management and initiate treatment only at this point. After that, we have to do the diagnostic test confirming a lesion or disease of the somatosensory nervous system explaining the pain. If yes, it is definite neuropathic pain. As Professor Myin Wu mentioned, neuropathic pain can be divided etiologically into two types. One is central and another is peripheral pain. Central pain is from the cortical, subcortical, thalamus, brainstem, and spinal cord. And peripheral pain is from the cranial nerves, nerve roots, and posterior ganglia, and the peripheral nerves and the complex regional pain syndrome. This is examples of the neuropathic pain. Prof. Myin already talked about that. And there are the post-hepatic neuralgia, painful diabetic neuropathy, low back nerve root pathology. These three are the peripheral type of the neuropathic pain. And the spinal cord injury, multiple sclerosis, and the stroke are the examples of the central type of the neuropathic pain. These are the common causes of the neuropathic pain, and this slide showed the common symptoms suggestive of the neuropathic pain. And neuropathic pain is important, should be treated because it has a significant impact on the patient's quality of life, social, economic, and the psychological well-being. Multidisciplinary team approach should be needed, including pharmacological treatment, cognitive behavior therapy, and the rehabilitation therapy. Regarding the pharmacological treatment of the neuropathic pain, there is a drug classes. One is the tricyclic antidepressant, second is a SNRI, and third is a alpha-2 delta ligands, and opioids, AEDs, and the topical agents. Now I'm going to discuss about the guidelines, recommendations for the pharmacological treatment of the neuropathic pain. And this is the NICE guideline, last updated September 2020. And this is a new UPS-ING recommendation in 2015. This is a European Federation of the Neurological Societies 2010 version. And this is an evidence-based recommendations to the 2017, and this is a Japanese Society Neuropathic Pain Guideline 2018, and this is a EN Guideline 2019 for trigeminal neuralgia, and this is a WATAG Guidelines for the neuropathic pain in 2017, and this is the IASP International Association for Study of Pain 2018 Guideline. And This table is very important and shows that the comparison of the recommended drugs for the neuropathic pain from various international guidelines. In the Canadian Guideline 2014, first-line drugs are the gabapentin, pregabalin, and SNRI, and tricyclic antidepressant. In the Neuropathic Pain Special Interest Group Guideline in 2015, first-line drugs are the same as the Canadian Guideline. In the Western Australia Therapeutic Advisory Group Guideline in 2017, first-line drugs are the tricyclic antidepressants and the SNRI. In the AN Guideline in 2017, first-line drugs are the same as the other countries' recommendations such as the tricyclic antidepressant, SNRIs, and gabapentin and pregabalin. Apart from that, topical lidocaine is added in this AN Guideline. In Japanese Guideline 2018, first-line drugs are the gabapentin, pregabalin, and SNRI. In the International Association for the Study of Pain 2018 Guideline, first-line drugs are the same as other. Finally, in the NICE 2020 updated guideline, the additional first-line drug is the topical capsaicin cream for the localized neuropathic pain who wish to avoid or cannot tolerate oral treatment. In comparison of the first-line drugs from the 2014 to the 2020, first-line drugs of the various international guidelines are more or less the same, and the additional drugs for the American and European guidelines are topical applications such as the lidocaine and capsaicin. The second-line drugs from the Canadian Guideline 2014 are the tramadol and opioids. The Neuropathic Pain Special Interest Group Guideline 2015, the second-line drugs are the tramadol and topical application. In the Western Australia Therapeutic Advisory 2017 Guideline, the second-line drugs are the pregabalin and the gabapentin. In the AN Guideline 2017, second-line drugs are the tramadol and opioids. In the Japanese Association Guideline 2018, second-line drugs are the tramadol, and for postherpetic neuralgia, ERV vaccine is recommended. In the International Association for the Study of the Pain 2018, second-line drugs are topical applications and tramadol. In the NICE 2020 updated guidelines, if initial treatment, that is the first drug of the first line, is not effective nor tolerated, offer one of the remaining three drugs, and if the second and third drugs tried are not effective nor tolerated, we have to consider switching again. For second-line drugs, tramadol, opioids, and the topical applications are mostly recommended. In the Canadian Guideline 2014, third-line drug is cannabinoids. In the Neuropathic Pain Special Interest Group 2015, third-line drugs are strong opioids and botulinum toxin A. In the Western Australia Therapeutic Advisory Group 2017, third-line drug is the tramadol. In the AN Recommendation 2017, third-line drug is cannabinoids. In the Japanese Association Guideline 2018, third-line drugs are the opioids and tramadol, and transdermal applications such as the fentanyl patches. In the International Association for the Study of Pain 2018, third-line drug is a strong opioids. In the 2020 updated NICE guideline, tramadol is considered only if the acute rescue therapy needed. The fourth-line drug in the Canadian Guideline 2014 is a topical application and botulinum toxin A. In the Western Australia Therapeutic Advisory Group 2017 Guideline, the fourth-line drugs are the opioids. In the AAN 2017 Guideline, fourth-line drugs are the AEDs and SSRI. In the NICE 2020 updated guideline, fourth-line drugs are the local application cream from the localized neuropathic pain if the patient cannot tolerate oral treatment. This table showed the neuropathic pain medications approved by the US Food and Drug Administration. carbamazepine in the trigeminal neuralgia, and the duloxetine, pregabalin, and the capsaicin cream in the painful diabetic neuropathy, and gabapentin, pregabalin, and the topical lidocaine and capsaicin local application in post-hepatic neuralgia. Now, I would like to discuss the stepwise process to follow. And firstly, we should start with the one medicine with a low dose and gradually titrate to attain the maximum benefit or maximum dose tolerated and allow adequate trial period to assess response. And also regular reassess and the close monitoring are needed. If response of the initial drug is inadequate or side effects experienced, we have to consider changing to another medicine and also consider the adjuvant therapy or adding a new class of medicine. Finally, regular re-evaluation should be needed. And these are the factors to consider when selecting the pain medicine for a given patient. The selecting drug should have the efficacy for the specific pain type, and we have to consider tolerability of the drugs, which include adverse effects and the potential adverse outcome. Drug interaction is also important. For example, serotonin toxicity may result when the serotonergic agents are used together. Also consider patients' comorbidities like the impaired renal functions and diabetes mellitus, etc. And patients' ability to adhere to the potentially complex medications regime is also an important factor. We also have to consider the risk of the medication abuse. For example, tramadol, opioids, and the now alpha delta ligands are appeared to addict in some papers. And the risk of the intentional or the accidental overdose should be considered. And for the prevention of the transition to the persistent pain, early treatment should be needed. And finally, I would like to stress that the timely referral is important to specialists or the pain clinic if the patient fails to respond to the treatment options and the patient presents with the complex pain issue. And take-home messages are the effective first and second line therapies include the tricyclic antidepressant, duloxetine, venlafaxine, and gabapentin, pregabalin, and the topical applications from the different international guidelines for treating neuropathic pain. But the limitations to treatment because of the incomplete pain relief and medication side effects profile. So, future research regarding the use of the validated screening tool, multimodal medication combinations, and phenotyping are needed. These are the reference, and thank you very much for your attention.
Truly for a very informative talk. And so I would like to invite my co-chair for the introduction to Professor Kimula.
Yeah. I'm Professor Mitang, co-chair of this session. So I would like to invite our last speakers, Professor Kimula, for the presentation about the rehabilitative perspective of the neuropathic pain. Professor Kimula is currently a past president of the Myanmar Society for Study of Pain and president of the Myanmar Rehabilitation Society. So I would like to kindly call upon Professor Kimula to present your presentation.
Good afternoon, Mr. Chairperson, Madam Chairman, and ladies and gentlemen. Thank you for inviting me, and this is a great honor for me for being part of this symposium. Today, I'm going to talk about rehabilitation perspectives in management of the neuropathic pain. These are the contents of my talk. I will start with the introduction, which will be followed by the common etiologies of the neuropathic pain and how we manage neuropathic pain patients in the rehabilitation practice, which will be followed by the take-home message. According to the new definition of the International Association for the Study of Pain. Neuropathic pain is defined as pain caused by the lesion or disease of the somatosensory nervous system. Neuropathic pain is a complex and heterogeneous condition with negative impact on physical, mental, and professional quality of life and associated with high healthcare cost. Neuropathic pain has a complex, severe, and persistent character with varying intensity and duration. It may accompany the many diseases, but can also be related to the injury. Neuropathic pain affects 1 to 5% of the world population, according to the data from ISB in 2011. The quality of life for the individuals with neuropathic pain is low, and it is more dependent on the severity of the neuropathic pain than on its underlying causes. Neuropathic pain can be caused by the central and peripheral mechanisms. These are the causes of the neuropathic pain conditions. Among these conditions, these are the common causes of the neuropathic pain. In the rehabilitation practice, 67% of the patients with spinal cord injury suffered from the neuropathic pain. Painful diabetic neuropathy, for the type 2 diabetic patients, it is 26% of the patients will suffer from the neuropathic pain. Low back pain and nephropathology patients are suffering from the neuropathic pain from 10 to 17%. Multiple sclerosis is 28%, and post-hepatic neuralgia and the stroke has 8% of the neuropathic pain. How do we manage neuropathic pain? Actually, neuropathic pain is difficult to handle. So it is very important to treat the patient effectively as early as possible. Even the patient has received all sorts of the treatment mechanisms, like a pharmacological, non-pharmacological, and surgical management. Sometimes patients still have a dissatisfaction for the treatment and they are still suffering from the neuropathic pain. So the several best practice guidelines proposed to the standardized treatments. This is a multi-professional approach and the multi-modal approach of the pain, which includes a pharmacotherapy, interventional approach, surgical, rehabilitation, psychological support, complementary alternative medicine, psychosocial approach, etc. Pharmacological pain relief is a part of the total plan for living with the pain, which focuses on improving the patient's quality of life and ability of the function. Together with the medical management, non-pharmacological treatment such as the physical measures, cognitive behavior therapy, and meditation can help in accepting and coping with the pain. These are the treatment modalities for the neuropathic pain: pharmacological management, non-pharmacological and invasive techniques, surgical management, and psychosocial and behavior approaches. Today, I'm going to focus mainly on the non-pharmacological and some of the invasive techniques and psychosocial and behavior approaches. Now comes from non-pharmacological management. The main aims of the rehabilitation in management of the neuropathic pain are to decrease the pain and amount of the medication, to improve the functional status of the patient, to increase the quality of life and physical activity, to bring the patient's self-esteem back, and to reduce the subjective reported pain intensity and the maladaptive pain behaviors. Physical modalities are one of the integral parts of the treatment in management of the neuropathic pain. According to the new ISB study, neuropathic pain assessment can be categorized by the possible, probable, and definitive. The clinical history of the disease or lesion of the somatosensory system suggests a possible diagnosis of the neuropathic pain. Confirmation by the either clinically reproducible signs or investigations would suggest a probable diagnosis of the neuropathic pain. And if the history, clinical examination, and investigations are positive, this would support the definitive diagnosis of the neuropathic pain. These are the rehabilitation techniques. We manage the patients from neuropathic pain in our rehabilitation departments. These are the physical modalities: therapeutic exercise and post-steroid care, relaxation technique, acupuncture, neuro therapy, cognitive behavior therapy, self-care, self-management, and self-development, and etc. Physical modalities are the non-invasive interventions. These include therapeutic heat and cold, electrotherapy, laser therapy, traction, and manual therapy. According to the evidence-based practice, all these physical modalities, and some of them are acting on the peripheral mechanism, and some of them acting on the descending modulatory pathway. Dance is the most studied physical modalities in the management of the neuropathic pain. The mechanism is based upon the two theories. One is the gate control theory. When high frequency dance stimulate the large fibers to inhibit the fibers with the A delta and C fibers, so that the pain gate can be closed. And the second theory is that the opioid mediated control theory, that when we use a high frequency dance, it increases the concentration of the beta endorphins in the bloodstream and CSF, and methionine enkephalin in the CSF in the human subjects. Thus, high frequency dance produce analgesia by activating the endogenous inhibitory mechanisms in the central nervous system involving opioid GABA and muscarinic receptors. In management of neuropathic pain, we also use the low frequency dance as well. This low frequency dance modulate the descending pain modulatory mechanisms. Dance is effective in the many neuropathic pain conditions like painful diabetic neuropathy, trigeminal neuralgia, cervical and lumbar radiculopathy, pain after stroke, pain after trauma, and compressive neuropathy. Laser is also effective in management of the neuropathic pain. It decreases the pain and inflammation, as well as improve the functional ability of the patients. For the cervical and lumbar radiculopathy, we use the traction together with the heat and cold modalities. The rationality of the traction is to provide the mechanical distraction of the vertebral bodies and the facet joints to reduce the pain from the nerve irritation. Traction also stretches the soft tissues, and it facilitates in breaking the pain, tightness, and pain cycle. What about the acupuncture? So according to the evidence-based studies, researchers have considered the acupuncture to be a form of the neuromodulation. There's two theories for the acupuncture. So one is the pain gate control theory. The first thing is the acupuncture may stimulate the last sensory efferent fibers, and it suppresses the pain perception, as explained by the gate control theory of the pain. Second mechanism is that when the needle is inserted, it may act as a nausea stimulus, and it induces the endogenous production of the opioid-like substances to affect the pain control. Acupuncture has been found to improve the pain and function for 3 to 12 months in treatment of the lumbar radiculopathy and in some high-quality trials. What about the phantom limb pain, and how do we manage? According to the studies, 50 to 90% of the amputees are having a neuropathic pain, but only 5 to 10% of the patients complain of the severe phantom limb pain. The prevalence of the phantom limb pain varies according to the characteristics of the population and pre, peri, and post-amputation anesthetic procedures. Among the non-pharmacological options, relaxation is associated to 41% success, tense to the 28%, and hypnosis with the lowest success rate of the 19%. Another aspect of the management for the neuropathic pain, phantom limb pain, is the mirror therapy. In this picture, mirror is placed at the mid-surgical plane of the patient so that the healthy side image will be superimposed on the projection of the affected extremity. Thus, there's a visual illusion of the increased movement ability of the paretic extremity. If the effect of the mirror therapy in combination with the conventional physiotherapy, it can significantly improve the motor function and to relieve the phantom limb pain, to improve the functional independence of the extremity, and to reduce the spasticity as well. The mechanism of the mirror therapy is that motor areas of the lesion hemisphere receive the visual motor processing information through the parietal occipital lobe. The damaged motor cortex responds variably to the mirror therapy and may augment the true motor recovery. Mirror neurons may also play a possible role in the corticostimulatory mechanisms occurring due to the mirror therapy. For the complex regional pain syndrome, mirror therapy, mental imagery, and discriminative sensory training strategies are applied to the patients with CRPS. We also use a peripheral stimulation with the surface electrodes like TENS, which seems to be more effective when it is associated with the exercises. Another kind of the non-pharmacological management is the self-care and self-management. Self-directed interventions are a very good way to regain a sense of the independence and maximize overall well-being and quality of life. Another one, the reconditioning of the body, therapeutic exercise, and body awareness and postural care. exercise are always effective not only in the pain, but also for the other health conditions. Therapeutic exercise can be classified to include the range of motion exercises, stretching, strengthening training, and the cardiovascular endurance aerobic conditioning. These programs should emphasize the education, patient self-independence, and the importance of an ongoing self-directed exercise regime. Aquatic therapy or exercise may be beneficial for the individuals who have other medical problems or conditions that make weight-bearing exercises are inadvisable. The benefits of the exercise training include the improvements in the nerve function, reductions in the neuropathic pain, reduction in other types of the sensory dysfunction, and improvement in both static and dynamic functional mobility in those with the peripheral neuropathy. When you manage a chronic neuropathic pain, this neuropathic pain experienced by the patient is shaped by the myriad of the biomedical, psychosocial, for example, patient's beliefs, expectations, and mood, and the behavioral factors such as context and responses by their significant others. By assessing that each of these three domains through a comprehensive evaluation of the person with a chronic pain is essential for the treatment decisions, and it will also facilitate the optimal outcomes of the patient's pain. Another approach is the psychosocial and behavior approaches. Cognitive therapy techniques are based on the notion that one's cognitive can have an impact on the mood, behavior, and physiological function. Cognitive behavioral therapy is a psychosocial intervention that aims to improve the mental health. CBT focuses on challenging and changing unhelpful cognitive disorders like thoughts, beliefs, and attitudes and the behaviors of the patient. It can also improve the emotional regulation of the patient and development of the personal coping strategies that target the solving the current problems. These are the techniques, some of the techniques of these behavior approaches. So I'm going to touch something about the invasive interventions as well. In our reparation practice, we also use some epidural and nerve and facet blocks. For example, for the intrathecal opioid injection or infusion may be used for the neuropathic pain patients. And we also have epidural serial injections with or without local anesthetics may be used as part of the multimodal treatment regime to provide the pain relief in the selected patients with radicular pain or the lumbar and cervical radiculopathies. But this is, we use these injections with the ultrasound guided approach. Another invasive interventions is implemented devices, such as spinal cord stimulation. This spinal cord stimulation treatment include the field-back surgery syndromes with the radicular symptoms, complex regional pain syndromes, peripheral neuropathic pain, peripheral vascular diseases, and ischemic heart diseases. But these spinal cord stimulation implantable devices are not available in our country yet. This is our take-home message. Neuropathic pain is essential for the patient, and this multimodal approach is the most useful for the effective management for the neuropathic pain treatment. Together with the other approaches, main aim of the rehabilitation are to increase the pain and amount of the medication, improve the dysfunction, increase the quality of life and physical activity, and bring the patient's self-esteem back. It is very important to note that we have to treat the whole patient, not just to consider the specific injury or the condition of the pain. Non-pharmacological treatments, such as physical measures, exercise and postural care, cognitive behavior therapy, and meditation can help in accepting and coping with the pain. Physical, psychological, and social factors contribute to the patient's pain. Reassurance, education, and counseling plays an important part in the pain management approach. Prevention of the pain and its consequences is at least as important as treating the pain. So we have to keep in mind that the prevention of the pain and treat the pain as early as possible with the effective ways is the most effective, with the most beneficial for the patient with neuropathic pain, as well as it can reduce the burden of the patient. These are my references. That is the end of my presentation. Thank you very much.
illustrated presentation about rehabilitative perspective of neuropathic pain. I do believe that all three speakers have been clearly illustrated the different perspectives in management of neuropathic pain according to the evidence-based practice. So I think there will be a lot of questions from the audience to each speaker. So I would like to open the floor for the questions and answers now.
Yes. So
First question.
the first question is asked to the all panelists. Why some NSAID are effective in managing patients with neuropathic pain? Dr. Piuလေးဖြေလိုက်ရင်တော့ကောင်းမှာချင်တယ်နော်
ကိုလည်းပြောလို့ရတယ်ဘယ်လိုပြော
Why some
speaker
သူက
ဒီ
all
တိုင်းပြောလို့
panelists
ရ
ကို
တယ်နော်
all panelists ကိုမေးထားတော့လေကြိုက်တယ်
မေကွန်းအားလုံးပဲမင်္ဂလာပါမေကွန်းအတွက်ကျေးဇူးတင်ပါတယ်ဦးရင်းပေါ့နော်ဒီဟိုပိန်းနေအားလုံးအတွက်ပေါ့နော်ဒီ NSAID ပေါ့ NSAID ကိုသုံးလို့ရသလားဆိုတော့သူ့ရဲ့ mechanism ပေါ့နော်သူ့ရဲ့ mechanism ကဘာလဲဆိုတဲ့အခါကျတော့ဒီ NSAID တွေကဒီ citric acid cycle မှာဆိုလို့ရှိရင်သူ prostaglandin production ပေါ့နော်သူကအဲ့ဒါကို inhibit လုပ်တယ်inhibit လုပ်ပြီးတော့သူ့ရဲ့ role က central peripheral sensitization ကိုသူက reduce ဖြစ်စေတယ်ပေါ့နော်အဲ့ဒါကြောင့်မို့လို့သူကဒီ neuropathic pain တွေပေါ့ neuropathic pain တွေအားလုံးမှာဒီ NSAID ကိုစပြီးတော့သူကစပေါ့နော်အကုန်လုံးသုံးလို့ရတာအဲ့ဒါကြောင့်မလို့ဖြစ်ပါတယ်အဲ့တော့သူကဆိုလို့ရှိရင်ဒီအဓိကတော့ nerve injury ပေါ့ due to inflammation အဓိက inflammation ကြောင့်ဖြစ်တဲ့ nerve injury တွေမှာသူကသုံးတယ်အဲ့တော့အသုံးအများဆုံးကဘာလဲဆိုတော့ ibuprofen ပေါ့နော်အဲ့ဒီ NSAID က neuropathic pain တွေမှာသုံးတာများပါတယ်
အဲ့ကိုမြင့်ဦးကရောဘယ်လိုလေးများဖြေချင်သေးလဲမသိဘူး Professor မြင့်ဦး
ဟိုအမဖြေသားမှာစုံပါတယ်အမသူကလည်းဟိုတုံးလို့ရပါတယ်အမကျွန်တော်တို့เนาะဟုတ်ကဲ့အမတိတ်ခက်ပြောကြမရှိပါဘူးခင်ဗျဟုတ်ကဲ့
ကိုမြင့်ဦးအတွက်ပေါ့နော် In post-stroke central pain is a neurogenic or neuropathic pain post-stroke central pain က neurogenic pain လား neuropathic pain လား
Okay အမ thank you ပါအမဒီ question ကတော့ very good question ပါကျွန်တော်တို့ neurogenic pain မှာတော့ type တွေပြန်ကြည့်မယ်ဆိုတော့ neuropathic pain ဆိုတာရှိတယ် neuropathic pain ဆိုတာဘာလဲဆိုရင်တော့ဒီ peripheral ဒီ nerve disease or nerve damage ဖြစ်လို့ရတဲ့ pain ပေါ့အဲ့ဒါ neuropathic pain ဖြစ်တယ်နောက် another type of neurogenic pain ကတော့ကျွန်တော် central pain ဖြစ်တယ် central pain မှာတော့ one of the good example တော့ကျွန်တော်တို့ဒီ post stroke pain ဖြစ်ပါတယ်နောက် post stroke pain ကတော့ဒီ central pain ဖြစ်တယ် neurogenic pain တစ်ခုဖြစ်ပါ neuropathic pain လို့ခေါ်လို့မရပါဘူးခင်ဗျ
How would we choose right drug for the patient as tricyclic antidepressant, SNRI and goblins?
ကျေးဇူးတင်ပါတယ်မေကွန်းအတွက်ကိုအဲ့ဒါတော့ကျမရဲ့ presentation မှာပြောထားတဲ့အတိုင်းပေါ့နော်သူက step wise approach နဲ့သွားတယ် neuropathic pain တခုတွေ့ပြီဆိုလို့ရှိရင်ဘယ်ဆေးကိုသုံးရမလဲဆိုတဲ့ဥစ္စာပေါ့နော်အဲ့ဒီမှာဘယ်ဆေးကိုရွေးမလဲဆိုတဲ့အခါကျတော့သူက individualize ပါ patient ပေါ်မှာမူတည်တယ်နောက်ပြီးတော့ other patient ရဲ့ဒီ comorbidity တွေပေါ်မှာမူတည်တယ်သူရဲ့ cost effectiveness ပေါ့နော်အဲ့ဒီပေါ်မှာလည်းမူတည်ပါတယ်အဲ့လိုမူတည်ပြီးတော့ရွေးချယ်တယ်အဲ့လိုရွေးချယ်တဲ့အတွက်ကြောင့်မလို့ဒီ guidelines တွေမှာတော့ဟိုအများအပြည့်ဟိုပေးထားတာ recommend လုပ်တာတော့ tricyclic antidepressant နဲ့စရပေါ့နော်သူကဈေးလဲနည်းနည်း fair ဖြစ်တယ်နောက်ပြီးတဲ့အခါကျတော့ side effects ကလည်းနည်းနည်းနည်းတယ်ပေါ့နော်ဆိုတဲ့အတွက်ကြောင့်လို့သူ့ကိုသုံးတယ်ပြီးတဲ့အခါမှာဒုတိယအနေနဲ့ကတော့ venlafaxine ပေါ့အဲ့တော့တဲ့အခါမှာဆေးတစ်မျိုးတည်းကိုသုံးမယ်သူရဲ့ effect လာတဲ့အထိစောင့်ကြည့်မယ်ဆို at least 2 weeks ပေါ့သူတို့ trials တွေကတော့များသောအားဖြင့်1 month เนาะ 1.5 month 2 months အဲ့လိုသုံးကြည့်ကြတာပေါ့เนาะအဲ့လောက်တော့စောင့်ရမယ်ပြီးလို့ရှိရင် SNRI နေပေါ့ duloxetine ပေါ့เนาะဆိုအဲ့လိုမျိုးတွေသုံးတယ်ပြီးတဲ့အခါကျတော့မှ delta 2 alpha ligands တွေပေါ့เนาะ pregabalin တို့ gabapentin တို့เนาะအဲ့လိုမျိုးကိုသုံးပါတယ်ဆိုတော့ဒါကတော့ according to individualized ပေါ်မှာမူတည်ပြီးတော့ tricyclic antidepressant တွေသုံးမလားခုနကတော့SNRI တွေသုံးမလား pregabalin သုံးမလားဆိုတာကတော့ဒီ patient ပေါ်မူတည်ပြီးတော့ပဲရွေးပါတယ် decide လုပ်ပါတယ်
Now question တစ်ခုက if carbamazepine cause Stevens-Johnson syndrome in trigeminal neuralgia patient what will be the second choice
အဲ့တော့ဟုတ်ပါတယ် trigeminal neuralgia မှာဆိုလို့ရှိရင်ဒီ uremia เนาะစာပေါ့ carbamazepine ကဆိုလို့ရှိရင်သူက notorious side effects က Steven Johnson syndrome အဲ့တော့သူ့ထက်နဲ့တစ်ဆင့်နည်းနည်းလေးပေါ့နော် effective နဲ့ urine ပေါ့နည်းတဲ့ဥစ္စာဆိုရင် oxcarbazepine ပေါ့နော် oxcarbazepine ကိုသုံးတယ် first line အနေနဲ့ပေါ့နော်အဲ့တော့ second line အနေနဲ့ကတော့ other drugs တွေကိုရွေးချယ်လို့ရပါတယ်အဲ့ဒါတွေကတော့ဘာလဲဆိုတော့ AED တွေပေါ့နော် AED တွေမှာဆိုလို့ရှိရင် lamotrigine တွေရှိတယ်နောက်ခုန gabapentinoids တွေပေါ့နော် gabapentinoids ဆို gabapentin တို့ pregabalin တို့အဲ့ဒါတွေရှိတယ်နောက်ပြီးတဲ့အခါ muscle relaxant တွေပေါ့နော် baclofen တို့ပါတော့အဲ့ဒါတွေသုံးတယ်နောက်ပြီးတဲ့အခါကျတော့ botulinum toxin A ပေါ့နော်အဲ့ဒါလည်းသုံးတယ်နောက်မြေသိပ်ပြီးတော့မရဘူးဆိုလို့ရှိရင်တော့ surgery ပေါ့နော် surgery ဆိုလို့ရှိရင်ခုနောက်ပိုင်းမှာဆိုရင် gamma knife တွေပါတွေသုံးတယ်နောက်ပြီးတဲ့အခါကျတော့ခုလောလောဆယ် ongoing ပေါ့နော် novel drug ကတော့ selective sodium channel blocker ပေါ့နော်အဲ့ဒါသူတို့ try လုပ်နေပါတယ်သူကတော့ ongoing ပဲရှိပါသေးတယ်